everyone. I'm going to present my PG capsule case report from eye to system lupus retinopathy in a new SLE case. SLE, as we know, is a chronic autoimmune disorder causing systemic inflammation and predominantly affects women of childbearing age. Ocular involvement is common in approximately 1/3 of patients but is often under-recognized, and the spectrum ranges from mild dry eye to severe retinal vasculitis or choroidopathy. And the risk factors for ocular involvement are presence of nephritis, APLA, hypertension or female gender. Ours was a case of 20-year-old female with progressive diminution of vision in both eye for 2 weeks associated with ocular discomfort and floaters. No history of trauma. On systemic examination, she had malar rash that worsened with sun exposure for past 1 month. Intermittent joint pain and stiffness was also present, and fatigue and occasional low-grade fever. There was no significant past medical history, and the patient was not pregnant at that time. On ophthalmic evaluation, the visual acuity was finger counting at 1 meter with PR accurate in right eye and finger counting at 3 meter in left eye. IOP and anterior segment was within normal limits. On fundus examination, there was tortuous retinal vessel and multiple cottonwool spots in both the eye with intraretinal hemorrhages. On further systemic investigation, we found her to be positive for anti-nuclear antibody and anti-DSTN antibody. Complement level was low and ESR CRP was elevated. Rest other blood examination was within normal limits. On ocular investigation, fundus autofluorescence was performed, and on OCT macula, there was intraretinal cyst more in the right eye and cottonwool spot in the both eye with macular edema. From medicine side, the patient was started on oral steroid with hydroxychloroquine and oral anticoagulant aspirin was started. On follow visit, her vision has improved to 6/36 partial in the right eye and 6/9 partial in the left eye with resolving macular edema. The systemic medication was continued. Now coming to what is unique in my case is that early onset lupus retinopathy, especially in a 20-year-old at the presentation, is uncommon, and ophthalmic manifestation served as a critical systemic clues for SLE diagnosis, and the retinal changes suggest an immune-mediated vasculopathy with diagnosis in the line of possible vasculitis or APLA, and there was effective response to systemic steroid and HCQ, and it highlights the importance of a multidisciplinary approach. And as clinical implication is, we can see that if we are starting a patient on HCQ, if there is no additional risk factor, we should begin monitoring after 5 years of drug therapy. But if there is impaired renal function or increased dose of hydroxychloroquine or chloroquine is used, we should begin monitoring after 1 year of drug therapy. We can go for OCT as an initial evaluation, and if it comes abnormal, we can go for HFA. And if HFA is also abnormal, we can go for multifocal ERG. And if we found toxicity in any of the 3 cases, we should stop the drug and look for an alternative drug. My take-home message is that ocular manifestation can reflect overall disease activity, especially in young patients with unexplained vision loss. Lupus retinopathy may indicate an underlying vasculitis or antiphospholipid antibody syndrome, which requires urgent evaluation on a systemic basis, and prompt systemic immunosuppressive therapy can reduce the need of invasive ocular procedure, and collaboration between different departments is crucial for optimal patient outcome. There is no financial disclosure associated. Thank you.
Harshita and then Mukta. One question, your diagnosis came from your skin lesions or the ocular findings gave you the diagnosis?
Sir, the patient presented directly to ophthalmology first, then we sent to medicine and then to derma.